Hello, this is Dr. Christopher Ferrigno. In this video, I'll discuss the joints of the lower extremity with particular attention paid to the hip and the knee joints. Here are the learning objectives for today. Let us begin with the hip joint. Similar to the shoulder, the hip joint moves in all planes. While the hip joint has inherently less overall mobility than that of the shoulder joint, it is much more stable. In the sagittal plane, the hip joint flexes and extends. In the frontal or coronal plane, the hip joint AB or abducts or AD or adducts, bringing the leg closer to midline. In the transverse plane, the hip joint internally and externally rotates. Note that a consequence of internal rotation of the hip joint is a foot that turns in or is pigeon-toed. Conversely, external rotation at the hip joint can manifest with the foot turned out. Picture D shows a combined planar motion called circumduction. The acetabulum is a structure contained in the hemipelvis or innominate bone. It is the socket portion of the ball and socket hip joint and is formed by the fusion of the ischium, ilium, and pubis. The inferior margin of the acetabulum is incomplete as the acetabular notch. The acetabular fossa forms the floor of the acetabulum. With the exception of the fossa and the notch, the remainder of the acetabulum is lined hyaline cartilage for articulation with the head of the femur. Like the glenohumeral joint, the acetabulum also has a fibrocartilaginous labrum that attaches to the acetabular rim and helps deepen the socket by about 10%. The acetabular labrum is in approximately this location, although it's hard to appreciate on this picture. The labrum makes a much deeper concavity compared to the glenoid fossa of the shoulder. The labrum increases the stability of the hip joint, important for its responsibilities in weight bearing and ambulation or walking. Running with the ligament is a small artery, the foveal artery, that contributes to the blood supply of the femoral head. This artery is also called the artery to the head of the femur. The transverse acetabular ligament bridges the acetabular notch. Here we see that ligament bridging this acetabular notch, and it joins the two ends of the acetabular labrum. This ligament consequently forms the acetabular foramen. Here we see the foramen, through which the nutrient vessels and the small nerves pass to supply the hip joint. Femoral acetabular impingement, or FAI, is a moderately common hip disorder. However, it is a relatively new diagnosis, so much so that when I first started my clinical practice in the late 90s, it didn't exist. If the acetabulum is enlarged by excessive spurring, the socket may come in contact with the femoral neck at the end range of motion, especially with full hip flexion, impinging the structures in the way, usually the superior labrum and possibly the articular cartilage. This is called a pincer lesion. Similarly, spurs on the superior aspect of the femoral neck may come in contact with a normal acetabulum, irritating any soft structure in the way. This is called a cam lesion. Sometimes both bony abnormalities can simultaneously occur. This disorder is more common in younger females, especially dancers. It is also more common in athletes who play hockey and in baseball catchers. Three ligaments reinforce the external surface of the fibrous joint capsule to strengthen and stabilize the hip. The iliofemoral or IF ligament reinforces the hip anteriorly and superiorly. The IF has an inverted Y-shaped appearance and attaches from the AIIS superiorly of the coxal bone to the intertrochanteric line of the femur inferiorly. It is quite strong, resisting hyperextension, which comes in handy during routine standing. It screws the femoral head into the acetabulum upon extension of the thigh. The IF is clinically known in orthopedic circles as the ligament of Bigelow. The pubofemoral ligament is triangular shaped and passes from the pubic bone to the femur where its fibers blend with the iliofemoral ligament. It reinforces the hip inferiorly and anteriorly and prevents over-abduction of the thigh. The ischiofemoral ligament reinforces the posterior aspect of the fibrous membrane. As its name implies, it spans from the ischium to the femur. Weakest of the three ligaments, it makes the hip joint vulnerable to posterior dislocation. One should note that the fibers of all three ligaments are oriented in a spiral fashion around the hip joint so that they become taut when the joint is extended. This orientation stabilizes the joint and reduces the amount of muscle energy required to maintain a standing position. When sitting, the ligaments become flaccid, creating two weak spots in the capsule. One weak spot is located anteriorly between the iliofemoral and pubofemoral ligaments. A second weak spot is between the iliofemoral and ischiofemoral ligaments. As you might imagine, these weaknesses contribute to the vulnerability of the hip joint, especially posteriorly. Speaking of vulnerability, there are three common clinical scenarios related to hip dislocations. Two of them are on this slide. The third is on the next. A congenital or developmental dislocation occurs when the acetabulum is insufficiently shallow and results in a femoral head that cannot seat itself properly. In approximately half of the cases, it occurs bilaterally, and girls are affected much more often than boys. Because the femoral head sits higher in the acetabulum, you'll see one leg that seems shorter than the other. To test for this, a Barlow maneuver is performed. Positive test occurs when the femur is easily dislocated, and it's also often associated with an audible click. When you, the clinician, attempts to place the femur back in the acetabulum, one might also hear a click. This is called the Ortolani's click sign and is also an indicator of hip dislocation. An acquired dislocation typically occurs during high impact injuries such as an automobile accident or during a landing from a fall from a great height. The femoral head dislocates, usually in a posterior direction between the iliofemoral and ischiofemoral ligaments. Once dislocated, the thigh assumes a position of slight adduction and internal rotation. Dislocation is quite common after hip surgery, especially hip replacements. The decreased integrity of a new joint enhances its vulnerability. Depending on the surgical approach, a series of hip precautions are often prescribed to help prevent a mechanical dislocation following the surgery. Such precautions include limited hip flexion, especially going past 90 degrees would be prohibited. No hip adduction past midline, and no hip internal rotation past neutral. So you might imagine that someone with hip precautions would not be able to cross their legs when they're sitting. They would also have difficulty sitting on the low surfaces such as a sofa, dressing, bathing, etc. Anything that puts their hip past 90 degrees. You can imagine reaching to the floor is very difficult in these patients. The blood supply for the hip comes from several sources. We already saw the foveal artery contained within the ligamentum teres femoris, serving the proximal femoral head. This vessel originates from the obturator artery, seen here. A larger blood supply comes off the deep femoral artery, which arises from the femoral artery soon after the inguinal canal. Soon after this takeoff, the medial and lateral femoral circumflex arteries exit off of the deep femoral and wrap around the distal femoral neck. These arteries give off retinacular arteries that are the primary supply for the head and neck of the femur. The largest contributor of the blood comes from the medial circumflex femoral artery. Now let's move distally to the knee joint. The knee joint is of particular interest for me and the focus of my research here in the Motion Analysis Laboratory at Rush. It is the largest synovial joint in the body. The knee is considered a hinge joint and participates mostly in flexion and extension. At first glance, this makes for a seemingly simple joint. It is anything but. It has a complex rotation component during the larger sagittal plane motions, helping to unlock and lock the knee during gait. Because the knee is weight-bearing, it relies heavily on the stabilization by primarily four ligaments, fibrocartilage, and it also relies heavily on the strength and coordinated action of the surrounding muscles and their tendons. At the knee joint, there are two separate articulations. The weight-bearing articulation occurs between the condyles of the femur and the medial and lateral tibial condyles, which form the tibial plateau. Like any typical synovial joint, articular hyaline cartilage lines the surface of the condyles. Here we see that articular hyaline cartilage. The second articulation is between the patella and the femur beneath it. This articulation is called the patellofemoral articulation. Notice that the fibula is not a component of the knee joint. The patella is the largest sesamoid bone of the body. A sesamoid bone is a bone that is suspended within a tendon. Functionally, the patella greatly increases the lever arm for the pull of the quadriceps muscle, and it directs that pull of the tibia anteriorly over the femur, thereby significantly reducing the wear of the tendon and the underlying bony structures. Paradoxically, the apex of the patella itself is oriented inferiorly, while its base is positioned superiorly. The posterior surface is the articular surface covered with hyaline cartilage that is seated in the anterior intercondylar fossa of the femur. The vertical ridge on the anterior surface of the patella aligns with the V-shaped intercondylar fossa on the anterior surface of the distal femur, allowing the patella to glide and to track appropriately during knee flexion and knee extension. Sometimes this tracking mechanism can be thrown off. Runners and those who participate in deep flexion activities are at higher risk for experiencing pain deep to the patella in a condition called patellofemoral syndrome, sometimes also called chondromalacia patella. It occurs when there is poor tracking of the patella relative to the patellar surface of the femur, and it can result in osteoarthritis within the patellofemoral compartment. Patellofemoral syndrome is very common in pubescent females, in part due to their quickly changing pelvis and hip geometry. The knee joint is a typical synovial joint complete with a synovial joint cavity, articular or hyaline cartilage, and a capsule made of an outer fibrous layer and an inner synovial membrane. The fibrous joint capsule attaches from the distal femur to the proximal tibia. Anteriorly, the fibrous capsule is reinforced by the quadriceps tendon, the embedded patella, and the patellar ligament. The synovial membrane lines the entire joint cavity except for areas occupied by articular cartilage, in which case the synovial membrane attaches to the periphery of that articular cartilage. Additionally, the cruciate ligaments, which are intracapsular ligaments, are covered on their surface by the synovial membrane. Although they are intracapsular, they are extrasynovial because they are outside of that synovial membrane. Above the patella, the joint cavity extends superiorly deep to the quadriceps tendon as the suprapatellar pouch. At its superiormost aspect, it is held up by the small articularis genu muscle, seen here, that keeps the pouch from collapsing and locking up the knee. This is of clinical importance to orthopedic surgeons, especially those performing knee replacement surgeries. The prepatellar and infrapatellar bursa allow the skin to move freely over the patella during flexion and extension of the knee. The infrapatellar fat pad, seen here, occupies the space deep to the patellar ligament. It provides some separation between the ligament and the bones. This fat pad can be problematic and can contribute to patellar tracking issues as well. There are 3 significant extracapsular ligaments that strengthen the knee joint. The patellar ligament is the distal continuation of the quadriceps tendon that passes from the patellar to the tibial tuberosity. The patellar reflex is tested by striking the patellar ligament with a reflex hammer. This allows the clinician to test spinal cord levels L2 through L4. There are also 2 collateral ligaments that become taut when the knee is extended. These are the MCL or medial collateral ligament and the LCL or the lateral collateral ligament. The MCL is also called the tibial collateral ligament because it attaches from the medial epicondyle of the femur, seen here, to the lateral surface of the tibia. At its midpoint, its deep fibers are firmly attached to the medial meniscus, seen here in the bottom right picture. Functionally, the MCL prevents excessive abduction of the leg at the knee joint. So in other words, it resists what we call a valgus stretch. So a valgus stress would be a stress with an impact from the lateral side, putting stretch on the MCL medially. Because the MCL is broader and longer than the LCL, it is weaker than the LCL. As such, the MCL is more commonly torn in contact sports. And because the MCL attaches to the medial meniscus, which is important clinically, the medial meniscus tends to tear when the MCL tears. So, with excessive force at the knee in particular directions, the MCL can a tear in the MCL can cause a tear in the meniscus. Conversely, as the meniscus starts to move, it can pull on the MCL and tear the MCL as well. The LCL extends from the lateral epicondyle of the femur to the head of the fibula. It prevents excessive adduction of the leg at the knee joint. In other words, it resists a varus thrust. A varus thrust is when you get a medial shot to the knee, which is pushing the knee outward into a varus deformity. Also appreciate that the LCL does not adhere to the lateral meniscus, as we can see up in there. We see some space between that lateral meniscus and the LCL, because the tendon of the popliteus muscle is interposed between the LCL and the lateral meniscus. We can follow this tendon in the upper right picture as it slides up between the LCL and the lateral meniscus. So what are menisci? The menisci of the knee are crescent-shaped wedges of fibrocartilage that deepen the articular surface and serve as shock absorbers to dampen compressive forces on the joint. So they increase the joint congruency, which means they improve the contact area between the femur, the distal femur, and the proximal tibia to increase the stability at the knee joint. The menisci are thicker at their periphery, and their external margins are attached to the joint capsule. The transverse ligament of the knee joint joins the anterior edges of the menisci. The menisci are also attached to the intercondylar areas of the tibia as well. The medial meniscus is C-shaped and again is adherent to that medial collateral ligament.
As such, it is less mobile than the lateral meniscus, which is nearly circular in its appearance. The genicular anastomosis that surrounds the knee joint supplies the peripheral margins of the menisci with blood. And this is an important concept. So here on the bottom panel, we see an illustration that depicts that the lateral margins of this meniscus have a fair amount of blood supply. However, note that the medial 2/3 of the meniscus are relatively avascular, which means they have a decreased capability for healing. In regards to meniscal tears, a bucket handle lesion is the largest of all the meniscal tears. When you think of a bucket handle, you can envision the handle moving from one side of the bucket to the other. That's exactly what can happen. A sliver of the meniscus can flip over to lie in front of the femoral condyle or underneath it, thereby causing obstruction. Another common meniscal tear is a radial tear that radiates outward towards the periphery. The ACL, or anterior cruciate ligament, courses obliquely from the anterior intercondylar area of the tibia. So here we see the ACL arising from that anterior portion of the tibia. And it travels to the posterior aspect of the lateral condyle, the femur, which we can somewhat make out here on the right side of the picture. The ACL helps to prevent anterior displacement of the tibia with respect to the femur. It also helps to prevent the tibia from rotating internally with respect to the femur as well. It is the weaker of the two cruciate ligaments, in part because of its poor vascular supply. Because it's weak, it is more commonly injured than the PCL. The PCL, or posterior cruciate ligament, arises from the posterior tibia and attaches to the medial condyle of the femur. Its function is opposite to that of the ACL. It prevents posterior displacement of the tibia on the femur. Or you can think of it this way. When walking down a hill, it prevents the femur from sliding anteriorly off the tibial plateau. In the field, immediately after injury, or in the clinic soon thereafter, there are a few tests that one can do to assess the integrity of the ACL and the PCL. Two of them are shown here. The anterior drawer test, shown in the top, shows a clinician assessing for an ACL rupture. The body is relatively stable as it lies on the field or on the exam table, while the clinician tries to translate the tibia on the femur anteriorly by pulling towards him or herself. With an intact ACL, there would be translation, but it would be very minor, and there would be what we call a hard end feel, or a firm end feel, I should say. In other words, you would feel the ACL become taut. If there was a deficient ACL, there would be longer or further translation of that tibia on the femur. Similarly, testing the PCL, the reverse action is performed to assess the integrity of that PCL. The clinician or examiner pushes posteriorly on the tibia relative to the femur and feels again for that firm end feel where there is some translation and then it stops. If there's a large translation and it's a soft end feel, this indicates that there could be loss of the PCL. The ACL is commonly injured in sport, especially when cutting is involved. When the foot is in contact with the ground, the tibia tends to internally rotate and want to shift anteriorly, which is resisted by the ACL. When these forces of internal rotation and anterior translation exceed the tensile strength of the ACL, it ruptures. Sometimes this force is so great that other structures are also compromised. Internal rotation is usually accompanied by a valgus force, which stresses the MCL on the medial side. If a large valgus force occurs, like when an opposing player falls into the lateral knee, the huge stress causes an ACL and MCL rupture. And the failing MCL pulls on and tears the medial meniscus. This is called the unhappy triad, and you can imagine why. In this case, the ACL is reconstructed with a graft from the patellar ligament or the hamstring tendon. The MCL is reapproximated and repaired, and the bucket handle tear in the meniscus is excised, often resulting in a less stable knee. Insults such as an ACL tear, an unhappy triad, or occasional small trauma events can lead to long-term damage. Synovial joints are designed to withstand wear and tear, but it is not uncommon for degenerative changes to occur over time. Osteoarthritis is an example of a degenerative joint disease. Individuals with this condition experience joint stiffness, pain, and discomfort. The weight supporting joints, such as the knee and the hip, in addition to the carpometacarpal joint of the thumb, are the most commonly affected joints. Osteoarthritis is a disease of the entire joint with loss of articular cartilage, the production of osteophytes, subchondral sclerosis, and synovitis. All of these lead to chronic joint swelling, chronic pain, and long-term disability. A large percentage of individuals will experience this disease during their latter years of life. The divots in this image are signs of cartilage degeneration. Arthroscopy is one approach to repairing a joint in which bone spurs are removed and cartilage is trimmed. More severe cases often require partial or total joint replacement. Cartilage does not show up well in X-ray. In the radiograph on the left, this individual suffers from a degenerative joint disease in the form of osteoarthritis, specifically on the medial side. We see a loss of articular cartilage. Here there's no articular cartilage, while here the articular cartilage is preserved. We also see osteophytes as well as subchondral sclerosis. With the loss of the joint space, bone is now sitting on bone, which is very painful. Because cartilage does not regenerate, this individual is a candidate for total joint replacement, which you see in the right-hand side. So let's move on to the foot and the ankle.
The foot has a similar arrangement as the hand. The hand had a series of carpals and metacarpals, while the foot has tarsals and metatarsals in addition to the similar makeup of phalanges. So just like the hand, the foot has 14 phalanges. Digits 2 through 5 have a proximal, middle, and distal phalanx, while digit 1, the great toe or hallux, has only a proximal and a distal phalanx. The metatarsals are numbered in a similar fashion as the hand, where we have 1, 2, and 3, and then 4 and 5 metatarsals. And these provide a nice attachment point for some intrinsic muscles of the foot. Certainly we see some fracturing within these bones. Typically we see a fracture often of the fifth metatarsal, especially here what we call the base of the fifth metatarsal. This is probably a good point to talk about nomenclature, where we have a base here for all the metatarsals, and then the head is over here. And if you have a head, you typically have a neck somewhere in that region. And that goes the same for the phalanges as well, where the base is more proximal and the head is more distal. Looking more proximal on the foot, we have the tarsal joints. So let me just outline all the tarsal joints of the foot. So we have what we consider a rear foot, which is this area. And then we have a midfoot, which is the mid-tarsal area. And then we, of course, would have a forefoot as well in this region. So, let's turn our attention to the midfoot. And we have a few bones here. We have a very important navicular bone, which serves as the keystone for what we have as a longitudinal arch of the foot. From medial to lateral, we have a first cuneiform or a medial cuneiform, a second cuneiform, and a third cuneiform, or the medial, middle, and lateral cuneiforms. And then laterally, we have what's called a cuboid bone. Working our way back, at the bottom of the foot to the right, we have a calcaneus, and then we have a talus bone, which articulates with the tibia and the fibula. Note that there are combined joints formed between the rear foot and midfoot called the mid-tarsal joint or Chopart joint, and a joint between the midfoot and forefoot called the Lisfranc joint. The Chopart dislocation often occurs in the sagittal plane. Here we can clearly see the navicular bone being displaced dorsally on the talus. The Lisfranc usually occurs medial-lateral, where some component of the forefoot shifts relative to the midfoot. This is most clearly seen in this area, where the first metatarsal and the other metatarsals are shifting laterally with respect to the midfoot or the tarsal bones. Note that in this picture, it seems to be that there's a combination of both a Lisfranc dislocation, shown here with the two blue arrows, but if we look posteriorly, we can also see some semblance of a Chopart dislocation as well between the navicular and the talus. With these side views, we can appreciate the arches of the foot. In the top picture, we can view the medial longitudinal arch, with the navicular, seen here, serving as the keystone of the arch. We now have a good view of an important bony prominence, the sustentaculum tali, shown here, which serves as a pulley for the flexor hallucis longus tendon, a muscle of the posterior compartment of the leg. Also, the calcaneonavicular ligament or spring ligament attaches here. Let me draw in that ligament, which goes from the sustentaculum tali to the navicular bone. This ligament is crucial for the structural integrity of this medial longitudinal arch, and a lengthening or loss or stretch of that ligament will reduce the medial longitudinal arch, and the navicular will fall down towards the ground. In the bottom picture, we see a smaller lateral longitudinal arch, seen here. Interestingly, as the medial longitudinal arch falls, either with age or with structural weakness such as an inadequate spring ligament, the lateral arch often enlarges or raises. The ankle joint is complex and comprised of two articulations, the talocrural joint, seen roughly here, and the subtalar joint, seen roughly there, which we'll talk more about in a minute. The direct connection between the leg and the foot is the talocrural joint. This joint is considered a mortise and tenon joint. The mortise is seen here in orange, formed by the distal fibula and the distal tibia. The tenon is the superior talus called the trochlea, which fits up into the mortise of the tibia and the fibula. This configuration allows for a great deal of sagittal plane motion. At the ankle, this sagittal plane motion is called dorsiflexion plantar flexion, where dorsiflexion is extension or moving the foot and toes up towards the face. The upper foot surface is the dorsum of the foot. So here's the dorsum of the foot. So in dorsiflexion, you're bringing the foot dorsally, while plantar flexion is bringing the foot into the plantar direction, which is the plantar surfaces where the foot contacts the ground. So we go into plantar flexion, the foot is going down towards the ground. Realize in the previous picture, the arrow that pointed to the subtalar joint really was pointing to the articulation between the talus and the navicular. Here we can appreciate the subtalar joint drawn in blue. Realize that the subtalar joint is highly complex. There is triplanar motion at the subtalar joint. Now, going back when we looked at the talocrural joint, or that mortise tendon joint, we saw a lot of plantar flexion and dorsiflexion. Plantar flexion and dorsiflexion also occur at the subtalar joint with that triplanar motion. However, it's much less than at the talocrural joint. Here at the subtalar joint, though, we get a lot more eversion, inversion, so a lot more motion in the frontal plane compared with the motion that we saw at the talocrural joint. You do not need to know this entire slide. There are a few things that I do want you to know. First, what we're looking at is a medial view of the foot and of the ankle. So here we have the medial malleolus, so we're looking at the tibia. Obviously here we have the calcaneus. I'm going to circle in the sustentaculum tali, or at least the bony part that's showing here between all these ligaments, so you get a good idea of where that is. So what we have here in the writing is the deltoid ligament. So the deltoid ligament has four parts: the anterior tibiotalar, the tibionavicular, the tibiocalcaneal, and the posterior tibiotalar ligament. And while we do want you to know the four parts, clinically, I want you to remember that the deltoid ligament is extremely robust and strong. So much so that it often does not sprain or tear. Rather, you get an avulsion fracture here on the medial malleolus because of the strength of this deltoid ligament. Now, this would occur when you go into excessive eversion. In other words, the calcaneus rolls outward. The calcaneus rolls outward. The medial malleolus drives inward, and you put enormous stretch on the deltoid ligament. So in that process, again, the medial malleolus might avulse or might fracture rather than tearing the deltoid ligament. Another ligament to appreciate, again, is this ligament here. This is the plantar calcaneonavicular ligament, also called the spring ligament. So you can imagine that if we lose this spring ligament, that the arch will fall downward. Also, something to appreciate in this picture is the long plantar ligament. Again, now the long plantar ligament is positioned much more laterally than the spring ligament. And so the long plantar ligament plays a larger role in helping to support the lateral longitudinal arch of the foot. Once again, you do not need to know this entire slide. What I would like you to know is that on the lateral side of the foot, which we're looking at here, we can see the head of the fibula, and of course, again, the calcaneus. And if we take a sneak in here, we can appreciate the talus as well. So the lateral ligaments are extremely important. Why? Because they are often torn, especially in athletes or anybody who's walking down an irregular sidewalk, and you hit in a somewhat plantar flexed position where your foot is pointed downward but maybe turned in a little bit. We would call this position a supinated position. And as that heel hits the ground in a slightly supinated position, you put the lateral ankle into a vulnerable position. So we have this lateral ligament, and it consists of three parts. So we have the anterior talofibular ligament that we can appreciate here. This is one of the most torn ligaments in the body, and usually the culprit with a lateral ankle sprain. Then we have the calcaneofibular ligament and the posterior talofibular ligament seen back here. So these three ligaments give the ankle significant amount of support. However, they are extremely vulnerable to tearing. With this anterior view on the left and posterior view on the right, we get a very good look and we can appreciate two other often very overlooked ligaments in the lower leg. These are the anterior tibiofibular and the posterior tibiofibular ligaments. So as you might imagine, this tibiofibular ligament helps to support, or these ligaments help to support the distal tibiofibular articulation or syndesmosis between the two. So appreciate up in here we have this large interosseous membrane. Distally, this membrane becomes thickened and helps to form these two tibiofibular ligaments. If you've ever heard of a high ankle sprain is typically where the anterior and or posterior tibiofibular ligaments are disrupted, either torn completely or partially torn. These can obviously be quite painful and can change the dynamics of the articulation of the talocrural joint. Because if you have a complete tear of either of these ligaments, the spacing, let me change my color here, the spacing between the fibula and the tibia now change, so it gets wider. What that does is it forces the talus up further into this talocrural joint, thus limiting motion in dorsiflexion, plantar flexion, because there's too much congruency now. There's too much compression of this talus up into this mortise. A Pott's fracture is when either the medial or lateral or both of the malleoli fracture, particularly when there's an avulsion fracture. So these occur with forceful eversion or inversion. So if you recall, I mentioned that in forceful eversion, like we see on the left-hand side, instead of the deltoid ligament getting torn, because it's so strong, you can get an avulsion fracture of the medial malleolus. So this, in that case, that if that just occurred, that would be a Pott's fracture of the medial malleolus. In this picture, because it's so forceful, you get the avulsion fracture medially, and then you get the calcaneus that's pushing up against the distal fibula, which ends up fracturing that distal fibula. So you get a bimalleolar fracture, or the medial and lateral malleolar fracture. And this is another form of a Pott's fracture. So obviously this occurred with very forceful eversion. Conversely, you can get usually just a singular malleolar fracture on the fibula if you get forceful inversion. So again, in this case, those lateral ligaments, those talofibular and calcaneofibular ligaments, were strong enough to resist a forceful eversion, and instead the distal fibula fractured. The medial arch, comprised of the first metatarsal, first cuneiform, navicular, talus, and calcaneus, is supported by passive and active structures. Already mentioned, the spring ligament and the lateral plantar ligament support the arch. These are passive supports since they're non-contractile tissues. The medial longitudinal arch also has active supports in the form of several muscles. These muscles include those listed here, the tibialis anterior and the tibialis posterior, the flexor hallucis longus, flexor digitorum brevis, and not shown the flexor digitorum longus. We will be going into much more detail with all of these muscles in another lecture. So you might be asking, what is the function of an arch? Well, it distributes weight onto the head and the ball of the foot. It acts as a shock absorber during locomotion. It enhances the flexibility of the foot when planted on uneven surfaces, such as walking on pebbles or small rocks. Most importantly, it allows or enhances for gait efficiency by providing a less rigid foot during the middle of stance to accommodate the ground, while providing a rigid foot or lever during push-off later in stance. The lateral longitudinal arch also has both passive and active supports. So passively, we've already seen the lateral plantar ligament shown down in here with the red line and now the green line. We also have these active supports in the form of muscles, specifically the fibularis longus and the fibularis brevis muscle. We see this fibularis longus curving around the lateral portion of the foot and then coursing medially. We also see the fibularis brevis muscle, which has a very strong attachment onto the base of the fifth metatarsal head. Inadequacies in the medial arch, usually both in the passive and active components, result in a loss of that arch. This condition is called pes planus, or flat foot, and results in a loss of navicular height and an abducted foot. These changes have consequences throughout the limb, including more internal rotation of the leg and thigh due to internal rotation of the subtalar joint, increased knee valgus, and increased hip internal rotation. These individuals are therefore susceptible to other conditions throughout the lower extremity, particularly at the patellofemoral joint, since the patellar tracking may be off. Thank you for listening to this lecture regarding the joints of the lower extremity. Goodbye.